I've stopped prescribing one of the most commonly used diabetes drugs in the world. Not reduced it, stopped it. I'm an endocrinologist. I run a metabolic clinic. I've reviewed the treatment plans of over 2,000 patients with type 2 diabetes, and the pattern I kept seeing was making me angry. Patients over 60, HbA1c of 6.5%. On paper, perfectly controlled. In real life, falling, exhausted, in the ER. The drug wasn't failing to lower their blood sugar. It was doing its job too well. In this video, I'm comparing 3 drug classes: the old standard, the new favorite, and the quiet one nobody talks about enough, using what I call the 3-layer framework. What the drug does to your numbers, what it does to your body, and what it does to your life. Stay to the end. The 3rd layer is where most doctors stop short. So why am I talking about this now? The reason this comparison matters right now, 2025. The American Diabetes Association just updated its standards of care. The Japanese Diabetes Society released revised older adult targets. And 3 major cardiovascular trials, EMPA-KIDNEY, FLOW, and SURMOUNT-J, published results that changed how I practice. If you were prescribed your current diabetes medication before 2023, there's a real chance the evidence has moved past it. We're in a transition year. The drugs available now are not the drugs of 10 years ago. Comparing them, honestly, is overdue. Here's the 3 drug classes I'm comparing. First, sulfonylureas, the old warhorse, glipizide, glimepiride, glyburide. Cheap, generic, widely prescribed. Monthly cost under $10. Second, GLP-1 receptor agonists, semaglutide, tirzepatide, the headline drugs. Monthly cost $800 to $1,200 without insurance, with coverage often $25 to $50. Third, SGLT2 inhibitors, empagliflozin, dapagliflozin, the quiet ones. Monthly cost $400 to $600 without coverage, with insurance usually $30 to $60. Price difference matters, but by the end of this video, cost will be the least interesting part of this comparison. Before comparing these 3, one thing needs to be said clearly. Metformin. If you can tolerate it and your kidneys are okay, metformin is still the right foundation for most people with type 2 diabetes after 60. It's been studied for 60 years. It doesn't cause hypoglycemia. It doesn't cause weight gain. It may reduce cancer risk. For most patients, it's not the question. The question is what you add to metformin, or what you take instead when metformin isn't enough. That's the comparison. And that's where most of the mistakes happen. Let me show you what the head-to-head data actually looks like. The ACCORD trial compared very intensive glucose targets, targeting HbA1c below 6%, with standard targets in high-risk patients. The intensive arm had a 22% higher all-cause mortality. The trial was stopped early. This wasn't a failure of one specific drug. It was a failure of the concept of aggressive glucose control itself, pushing any patient with any regimen toward a number their body wasn't ready for. EMPA-KIDNEY, empagliflozin in patients with kidney disease. Significant reduction in kidney failure and cardiovascular death, even in patients with moderate CKD. FLOW, semaglutide in patients with type 2 diabetes and chronic kidney disease. It reduced the risk of major kidney outcomes by about 24%. SURMOUNT-J. In Japanese patients with obesity, tirzepatide led to roughly 18 to 23% weight loss at higher doses. Here's what the scores tell you. These drugs have entirely different specialties. Choosing by blood sugar alone is like choosing a surgeon based on their office location. Sulfonylureas are like a diesel freight train. A diesel freight train is powerful, but it's slow to stop once it's moving. And that's exactly the problem here. Reliable, powerful, but once it starts moving, it doesn't care whether you ate lunch or not. That's the mechanism. They stimulate insulin release around the clock. Blood sugar goes up, insulin goes up. But blood sugar goes down, insulin keeps going up anyway. That's hypoglycemia. Their strengths? Inexpensive. Effective at lowering HbA1c. Available everywhere. Their weakness after 60. That non-stop insulin release is dangerous when you sleep through the low, when you forget a meal, when your kidney function quietly declines. The American Geriatric Society lists long-acting sulfonylureas on the Beers criteria. Medications potentially inappropriate for adults over 65. That's not a fringe position. That's mainstream geriatric medicine. This is why I moved most of my older patients off them. GLP-1 receptor agonists are like a smart thermostat in your home. It turns on only when the temperature is off. They only activate when blood sugar is elevated, and go quiet when it's not. That's why hypoglycemia risk is very low. They do several things simultaneously. Lower blood sugar, reduce appetite, slow digestion, protects the heart. In the LEADER and SUSTAIN 6 trials, GLP-1 agents reduced major cardiovascular events in patients with type 2 diabetes. And in the SELECT trial, semaglutide reduced cardiovascular events by about 20%, even in people with overweight or obesity who didn't have diabetes at all, suggesting the protection extends well beyond glucose control. One note, tirzepatide, sold as Mounjaro or Zepbound, is technically a dual GIP and GLP-1 receptor agonist. It works on two pathways, which is likely why the weight loss data is even stronger than standard GLP-1 agents. Their weakness: cost without insurance. And for some patients, nausea, especially in the first weeks. But here's what I tell my patients. The nausea usually passes. The cardiovascular and kidney protection doesn't. SGLT2 inhibitors are like a silent bodyguard. You don't notice a good bodyguard until something goes wrong. And that's exactly how these drugs work on your kidneys and heart. They work by making your kidneys filter out excess glucose through urine. Quietly, continuously. Blood sugar goes down. So does blood pressure. So does the pressure inside your kidneys. They have a very low hypoglycemia risk. They don't stimulate insulin at all. Their protection is organ level, not just number level. The EMPA-REG outcome trial showed cardiovascular protection in high-risk T2DM patients. And EMPA-KIDNEY, a separate, more recent trial, showed kidney protection in CKD, chronic kidney disease, even when the glucose-lowering effect was minimal. Two different trials, two different organs. Both point the same direction. The thing I want you to remember is that SGLT2 inhibitors do something none of the others do. They protect you independently of your HbA1c. 5 criteria. 3 drugs. Hypoglycemia risk. Sulfonylurea, high. GLP-1, very low. SGLT2, very low. Weight effect. Sulfonylurea, neutral to gain. GLP-1, significant loss. SGLT2, modest loss. Kidney protection. Sulfonylurea, none. GLP-1, yes, flow trial. SGLT2, strong, EMPA-KIDNEY. Heart protection, sulfonylureas, none. GLP-1, yes. Leader and sustain 6 in type 2 diabetes patients. SGLT2, yes. EMPA-REG outcome trial. Monthly cost with insurance. For many patients, all three end up in a similar $10 to $60 range, depending on the plan. The sulfonylurea wins one column, cheapest without insurance. In every other column relevant to safety after 60, it finishes last. You've waited for this. Here is what I've actually seen in practice. 2 years ago, I had a 71-year-old patient, HbA1c, 6.7%. His previous doctor was proud of that number. His family brought him to me after his second fall in 6 months. When I reviewed his medication, he was on a sulfonylurea and a moderate dose of insulin. His nighttime glucose was dropping to 58 every third night. He had no idea. He thought he was just sleeping badly. We switched him off the sulfonylurea, adjusted his insulin, added empagliflozin. 6 months later, HbA1c 7.4%. 0 falls. He told me he started walking his dog again. That HbA1c went up. His life went up more. This is what I mean when I say the third layer. What a drug does to your life is where most doctors stop short. From here on, it's not data, it's what I've seen. 1. A 68-year-old woman on glipizide for 11 years. Switched to semaglutide. Lost 9 kilograms in 8 months. First time she's been able to kneel in her garden in 3 years. 2. A 74-year-old man with early CKD and HbA1c of 8.1. Started empagliflozin. Kidney decline slowed significantly. Avoided dialysis conversation for at least 2 more years. 3. A 65-year-old with well-controlled glucose but 3 ER, emergency room, visits for unexplained dizziness. All 3 were nocturnal hypoglycemia. Off sulfonylurea. No ER visits in 18 months. 4. A 70-year-old who refused GLP-1 due to cost. Switched to dapagliflozin. Adequate control, heart protection, affordable. 5. And this is today's hidden theme. The patient who needed neither a new drug nor a lower HbA1c. She needed a doctor to say, your target is 8%, not 7. Stop chasing a number that isn't yours. Here's how I think about it by patient type. If you're over 60, healthy, no major organ issues, and still on a sulfonylurea, ask your doctor about switching to a GLP-1 or SGLT2 inhibitor. If you have CKD or heart failure, SGLT2 inhibitor is often the first conversation. If you have obesity and cardiovascular risk, GLP-1 is compelling. If you're frail, in a care facility, or managing multiple conditions, the goal may be to simplify, not intensify. Less may be more. If metformin is working well with no complications, that conversation may not need to happen yet. The decision is individual, but you can't have the right conversation if you don't know the options. One important note. If you're watching this and feeling worried, please don't stop any medication on your own. Use this video as a starting point for a calm, informed conversation with your doctor. Earlier, I mentioned the 3-layer framework. Here's what I meant. Layer 1, the number layer. What does the drug do to your HbA1c? Sulfonylurea wins here, cheaply, reliably, for decades. Layer 2, the organ layer. What does the drug do to your heart and kidneys, independent of blood sugar? GLP-1 and SGLT2 win here, clearly with trial evidence. Layer 3, the life layer. What does the drug do to your ability to function, stay independent, avoid the ER? This is where sulfonylureas fail silently, through falls, fractures, and hypoglycemia no one noticed. Most prescriptions are written at layer 1. Most harm happens at layer 3. The SGLT2 inhibitors are notable because their layer 2 protection operates even when layer 1 is mediocre. They protect your kidneys whether your HbA1c is 7 or 9. Wait, so what about the drug that started this whole comparison? It's still available, it still works. For some patients under careful supervision, it's appropriate. But for most adults over 60, it should be the last choice, not the default. 4 things to remember. 1. Sulfonylureas carry real hypoglycemia risk after 60. The American Geriatric Society flagged them for a reason. 2. GLP-1 receptor agonists and SGLT2 inhibitors protect the heart and kidneys in ways that go far beyond blood sugar control. 3. Your HbA1c target should be individualized after 60 and may be higher than you think. That's not failure, that's good medicine. 4. If you haven't had a conversation about these options, you haven't had the full conversation. The 3-layer framework is what to bring to your next appointment. One question before you go. Are you or someone you care about still on a diabetes medication that was prescribed more than 5 years ago with no discussion of alternatives? If the answer is yes, that's the conversation to have next week. Subscribe for evidence-based clinical updates every week. Next video, the one blood sugar number that matters more than your HbA1c after 65. I'll see you there.